So, afternoon and a very warm welcome to what I hope is the first of a series of spinal injury seminars that we're planning to host as Chambers. And I think we were very much hoping to be welcoming a number of you in person at the Law Society, but hey ho, a wee dispute over transport pay I think it's got or put paid to those best laid plans. But happily, as you can see, it takes a little bit more than a strike to knock us off our stride. And we've got a fantastic program for you today, all focused on the issue of Cauda Equina Syndrome. So why did we start with Cauda Equina Syndrome? Well, as you all know, it's a very rare, but sadly potentially life-changing condition if the warning signs are missed and it's not addressed at an early stage. And in fact, in 2020, it was an area of focus for NHS Resolution, who reviewed all of the claims notified to them between 2008 and 2018. And over that 10-year period, interestingly, they received 827 claims, so a little over 80 a year. 340 were settled with damages paid, 275, I think, were remained open at the time of consideration, and 212 were unmeritorious. And of those 827, damages and costs totaled £186 million. So you can see why it was an area of particular interest to them. I'm glad to say that to assist us today, we have 5 fantastic 40-minute talks. John Leach, spinal neurosurgeon, is very kindly going to kick matters off for us, and he's going to deal with issues of diagnosis, surgical timing and causation. And that will be followed by Jonathan Hand and Dan Clark from Chambers, who will be providing an overview of the recent case law on Cauda Equina related cases. I think we then have a short break between 2:50 and 3, and Naveen Kumar, our spinal rehab expert, is very kindly going to be drawing upon his huge experience of managing such patients from Oswestry Street. Tom Gibson has an interesting talk at 3:40. He's going to be focusing on 2 Cauda Equina cases, which turned out to be catastrophic from a litigation perspective, both ending up with committals for contempt. And then at 4:20, Maggie Sargent, who I'm sure you all know, is going to be joined by her colleague and occupational therapist Jill Crichton. And they're going to be discussing through some of the journeys from the care and OT perspective of managing Cauda Equina patients. But importantly, Jill is also going to be drawing upon her own experiences. So really good program. Just a few housekeeping matters. I'm afraid to say we can't see you and you're not being identified, but each talk hopefully will become available in about a week's time. And we'll notify you of that. I'm afraid you can't unmute yourselves or put your videos on, but there is a Q&A box, and I'll be keeping a very careful eye on that. And hopefully, if there's time at the end of the talks, I will be able to sort of relay some of your questions. So do keep them coming in. I'm going to start off, if that's all right, with John Leach. John is clinical lead for spinal neurosurgery in Manchester. He's got his NHS practice at Salford Royal, and he serves, Salford serves as the neuroscience centre to the whole of the Greater Manchester region. And John's particular area of specialism is in minimally invasive cervical and lumbar spine procedures, and a particular interest in brain as well as spinal tumours. He's clinical chair of the Northwest Regional Spinal Network. He's responsible for, or his team are responsible for, about 7.5 million patients, I think, across the Northwest. And he also has a huge amount of experience as a spinal expert. He commonly is rescuing me in my cases, and I really value his input. So many thanks, John. Over to you.
Thank you very much, Elliot. Hopefully that's showing now. Thank you for the kind introduction. I'm really sorry that we can't be meeting face to face. It's always a little bit more difficult on a webinar. As Elliot said, my remit will be to talk to you about Cauda Equina Syndrome from an expert's perspective. I will touch a little bit on diagnosis because it's so important, but I'm sure many of you are hoping that I will concentrate on evidence for surgical timing and causation. As Elliot says, I do spinal expert work for both claimant and defendant. That's obviously not my main job. Salford Royal is a big unit. We have 38 surgeons now that perform spinal operations, and we have a correspondingly very busy on-call service. So Cauda Equina Syndrome is a daily problem for us to deal with clinically. As well as the sort of local roles Elliot touched on, I've been on NHS England's Spinal Services CRG for the last 6 years, and currently with peers, there's a national Cauda Equina Syndrome guideline working party. So hopefully there'll be some news in the not too distant future, the next few months, about a national guideline for this condition. So as well as doing expert work, working very hard in terms of organisation of services and guidelines to try and improve care. And while I mentioned the working party for the national guideline, which is run by GERFT, I do just want to touch on something Elliot talked about in the introduction, which is the problem of litigation for the NHS. The GERFT report came out around 3 years ago, and somewhat to the shock of a lot of my colleagues, it showed that NHS Resolution was paying out about £100 million a year for claims against spinal surgery. So in their 5-year study period, £500 million. That's clearly a problem for the NHS, for the taxpayer, problem for patients, and something that needs addressing. And one of the main remits of GERFT was to look at variations in healthcare and try and reduce unnecessary or unwanted variation. And if you take that into the area of litigation, this graph shows you that for every patient admitted for a spinal procedure in the NHS, you have to put aside £1,654 for litigation costs. So that's the average, but if the graph actually shows there's massive variation, and there are a large number of trusts where the cost per admission is more than £5,000. This plays into the concept that we're perhaps not very good at learning from our mistakes in the NHS, and we should be learning from other units and learning from previous case history. I'd also like to just briefly touch on one aspect of breach of duty, and that's nighttime surgery. I tend to take a very balanced view on this. We are, of course, keen that Cauda Equina patients are managed as urgently as possible, but there are some issues with surgery in the middle of the night. The old NCPOD, the National Confidential Inquiry into Perioperative Deaths, proved that surgery at night was associated with higher death rates and higher complications. And recently, colleagues from Cambridge produced a very nice paper showing that specifically for Cauda Equina surgery, there is a higher complication rate than dural tears and infections, etc., at nighttime, done between the hours of midnight and 8 a.m. And actually, that was still held true whether it was a consultant or a registrar operating. And there are obvious potential factors here like fatigue, poor skill mix of the overnight team who may not be used to spinal surgery. So I think when we're looking at breach of duty in particular, we need to consider the real world scenario. There's some very useful data produced by a trainees collaborative actually called Entice. And I'm just going to show this to you here. This is some data produced over a set period. This is Salford data benchmarks against UK, but they're very similar. So I'll just show you the UK data. And if you look, first of all, at the graphs on the right, this is time from referral to spinal surgery to decompression. And I've highlighted there on the right, the UK data. And the light blue is 24 hours. And each box represents the next 24-hour period. So the light green is 24 to 48, the pink 48 to 72, etc. So this graph is showing that 75% of patients are operated on within 24 hours of referral, which is what we would hope and expect. And the majority within 48 hours. Now, there may be some more work to do. There may be valid medical reasons why some of those other patients are delayed. They may be medically unwell, or perhaps the diagnosis was really suspected Cauda or impending Cauda Equina. But that's the data for referral to surgery. And if you move on to the left side now, and this is symptom onset to decompression. This is where the UK is at the moment. And surgery occurring within 24 hours of symptom onset is down around 20%. And within 48 hours is about a third. So that highlights what you're probably aware of in terms of your legal work, that there's a problem in terms of likely late presentation. So that's a problem of patient education and safety netting, and probably also a problem in terms of access to MRI and referral. But I thought that was quite useful real world data. So let's just take a step back and think about what Cauda Equina Syndrome is. It's actually quite difficult to define. It's a clinical diagnosis that needs confirmation on imaging. So you can't have Cauda Equina Syndrome without a scan showing compression of the Cauda Equina. You can't have similarly, a very large disc with Cauda Equina compression reported by a radiologist does not mean that Cauda Equina Syndrome is present in the patient. Here's a stab at it. So it's a term used to describe a constellation of symptoms and signs of compression of the lumbosacral nerve roots in the lumbar canal. Symptoms include disturbance of perineal sensation or saddle numbness with altered bladder, bowel, or sexual function in combination with acute back and or leg pain, leg numbness, and weakness. It's really quite a mouthful. It is actually possible to have Cauda Equina Syndrome without any leg pain, although that's rare. Cauda Equina Syndrome has become strongly linked with a large central acute lumbar disc prolapse, and that's the majority of what we're talking about today. But of course, it can be caused by other factors, such as tumor, trauma, and infection. Touching on diagnosis, for GPs and emergency department doctors, this can be quite stressful. How do you identify a patient with suspected Cauda Equina Syndrome? And we need to put this in the context that back pain is the second most common human condition after feeling sad. So non-spinal specialists will see many thousands of patients with back complaints that do not have Cauda Equina Syndrome. NICE produced an update to the clinical knowledge summary in 2018, and many of you will be familiar with this. I won't read through it all, but they put in for the first time bilateral sciatica. It includes bilateral deficit in the legs, difficulty passing urine or impaired flow, loss of sensation of rectal fullness, and then your saddle anesthesia and laxity of the anal sphincter. That all sounds quite straightforward. If the patient has these, you get them an urgent scan. What's the problem? Well, the problem is that we're very, very bad at determining who has Cauda Equina Syndrome. Even using the red flags, 90% of scans for Cauda Equina Syndrome will be negative. Urinary dysfunction, what is significant? If you have severe back and leg pain, you very often have a sense of altered urinary stream. It's not uncommon, and particularly common if you start on powerful pain medications, particularly neural analgesics. So trying to tease out what is parasympathetic bladder dysfunction from what is some other type of urinary dysfunction can be very difficult. And patients, of course, may have pre-existing bladder problems like stress incontinence, which won't be related to a Cauda Equina Syndrome, but all get thrown into the mix. Anal tone is a tricky one. As an isolated sign, it's probably not useful at all. I certainly can't remember seeing a patient with Cauda Equina that had lax anal tone without perineal numbness and bladder dysfunction, and Salford have produced some data on this. The really big problem with this new guideline is bilateral sciatica. Now, it was aimed at trying to prevent patients who are progressing. So it's a common story to have severe unilateral sciatica, then suddenly develop bilateral sciatica as a herald of Cauda Equina compression that then comes on. The problem is a non-spinal specialist finds it very difficult to tell what is radicular or nerve pain and what is other leg pain. So spinal stenosis will cause bilateral leg aching and leg pain, but it's not bilateral sciatica. Facet joint pain can be referred into the buttocks and the back of the thighs, but that's not sciatica. Orthopedic problems can cause leg pain. So it remains a real problem in terms of a non-spinal specialist making the call of suspected Cauda Equina. The real big issue in Cauda Equina Syndrome is emergency MRI access. there are potential barriers to an MRI, and I do have some sympathy with our radiologists. There's an issue of culture and education, and I think we're winning that battle slowly. I think amongst emergency departments and GPs, people are very well aware of the urgency of Cauda Equina. There was a workforce crisis in terms of MRI before COVID, and there just aren't radiographers around. MRI scanners stay on all night, so they don't need to be turned on and off. It's just the way they are. But it's very unusual for a district general hospital to have a MRI competent radiographer on call overnight. I think it's not unfair to say that amongst radiologists, there's been an unwillingness to interrupt planned scanning lists. And if you think about running a very busy MR schedule, 8 a.m. to 8 p.m., it is hugely disruptive to fit in an emergency where there's no planned emergency slot. I mentioned before that 90% of scans are negative, and so it can be hard to really push the point with our radiology colleagues, but most of the scans we're requesting actually make no difference to that individual patient's management. There's also an issue of quality of clinical assessment of an undertrained person making a poor decision about the patient who needs the scan. Pathophysiology. I'm aware that most of you are lawyers, and probably the word pathophysiology may induce a comatose state, so I'll keep this brief, but it is an important point. Have you ever wondered why sciatica, which is nerve compression via disc generally, is an elective problem that normally just gets better and is not an emergency, but Cauda Equina syndrome is an emergency? And of course, the answer is that not all nerves are the same, and that the nerves supplying the autonomic function and perineal sensation tend to be smaller unmyelinated nerves, that is, without a myelin sheath, and they are more vulnerable to pressure and therefore damage than the larger myelinated nerves supplying leg power and sensation. You should know a little bit about the autonomic nervous system, parasympathetic versus sympathetic. Sympathetic outflows from the spinal cord. So actually there are no sympathetic neurons in the lumbosacral canal. There's just the parasympathetic neurons. And for the bladder, there's an afferent limb, so towards the spine, that control a sense of bladder fullness, and an efferent limb away, which are responsible for helping the bladder contract. It does have natural detrusor muscle activity, the bladder, but the parasympathetic nerves assist in contraction. And this is why a Cauda Equina syndrome will give you an impaired sense of bladder fullness and an impaired ability to micturate in the early course of the syndrome. I need to also touch on the fact that if you allow a bladder to become over-distended, it can be irreparably damaged, so-called blown bladder, because of damage to the intrinsic detrusor muscle. Our urology colleagues on the national guideline are very keen that the guideline states that any patient who has Cauda Equina syndrome and is going to theatre has a urinary catheter inserted. This is in order to prevent the development of damaging retention. Just a word of caution then, I will talk in a moment about CESR. CESR does not just mean a patient with a catheter, and you're going to find in clinical cases that many more patients with a diagnosis of CESI will have a catheter inserted on the advice of our urology colleagues. And I'll talk a little bit more about the difficulty that can give us in terms of giving expert advice about when CESR comes on. In terms of sexual function, there's many factors that can affect sexual function. There's the altered sensation of the genitalia, which is somatic. In males, parasympathetic damage will impair erectile function. And of course, there can also be pain and psychological factors affecting sexual function. So this is a sort of tour de force of Cauda Equina, and I'm going to move on now to some of the evidence about timing of surgery. And I'll split it into three parts: the earlier evidence, the bulk of sort of case studies, and then some new evidence. So the most often quoted authors are Arn, Gleaver, McFarlane, and Todd. And I won't go through these in detail because I'm sure they're bread and butter to many of you. But the headline outcome from the Arn meta-analysis, which in the end looked at about 40 papers and 300 patients, was that doing surgery within 48 hours was better than after 48 hours for bladder outcome. But their study showed no evidence that doing surgery within 24 hours was better than 24 to 48 hours. And this brought on a sort of culture of the 48-hour culture, where many surgeons thought, well, I can just wait as long as it's within 48 hours, there's not really a problem. But of course, logically, for those that believed in a time-dependent effect, it didn't really make sense that there was no difference 24 to 48 hours. Cleveland and McFarlane then came along and wrote a review article, really, reflecting back on their much earlier case series from 30 years ago now, and identified a cohort of patients with painless retention and overflow incontinence. So that's our classic CESR, and they maintain these patients were very unlikely to get better. And the inclusion of CESR mixed with CESI in the ARM paper was, in their view, one reason why they failed to show a difference with very early surgery. Interestingly, when you read this review, Cleveland and McFarlane weren't really arguing for early surgery. They were upset that so many authors claimed Cauda Equina was an emergency in all cases, and very much wanted to make the point that there was a group of patients in which early surgery was not so important, CESR. Todd produced some useful research with some evidence for a time-dependent effect, looking at the usefulness of surgery within 24 hours, and very much promoted the argument that there's a continuum of harm and benefit in a condition that tended to follow a pattern of early or impending Cauda Equina through incomplete then to complete Cauda Equina syndrome. This slide is busy on purpose. So after that, we had a large number of articles, and this list is by no means complete. But I just want you to understand that the quality of studies is necessarily not very good in terms of trying to answer the questions you're asking of us. So they all tend to be retrospective reviews. No one is going to perform a randomized control study on Cauda Equina syndrome, because that would involve purposely leaving patients for, say, 48 hours to see what happens to them. That would be clearly unethical. So we are reliant on retrospective case series and then meta-analyses of those series. And I'm afraid in statistics, that means that most of the evidence can be subject to bias and can be potentially flawed. So McCarthy in 2007 looked at a series of their patients in Nottingham and actually showed no association between retention, incontinence, and poor outcome. Meanwhile, down the road, Qureshi and colleagues in Leicester looked at their series and said, well, actually, retention is the important thing rather than timing. So retrospective case series can throw up conflicting data, and that makes interpretation of the overall literature quite difficult. Thacker in 2017 usefully looked at about 4,000 patients. Probably huge numbers of patients, big data is the way to go here. But because they were looking at a database, unfortunately, the outcomes were not really very clinical in terms of bladder, sexual function, numbness, etc. They were just looking at length of stay, cost of care, those sort of healthcare economics outcomes. And they showed that earlier intervention for both CESI and CESR was associated with more favorable outcome. But didn't take us any further forwards in terms of the effect of timing on specific neurological outcome. We then moved on to the Shrikandaraja paper from Liverpool, which is quite an important one, and I will delve into that. And an interesting study from Belfast. So this Belfast study was 136 patients. Half of them actually had CESR, so quite a high proportion had painless retention, according to their analysis. There was only a minority of CESI, and interestingly, they had a large number of patients they described as CESS, or suspected. I think I would maybe call these impending Cauda Equina, and I assume they were cases with bilateral sciatica and massive discs, but I can't be sure. In Belfast, they showed that all patients had some improvement regardless of timing. They actually showed that the bladder outcome was worse in CESR operated early. So the first bit of that challenges the narrative that CESR outcomes are always poor. Many of them do improve, but also brought in the concept that patients can present in different ways, and there may be a subgroup of patients that present very early with very severe complete Cauda Equina that may do very badly. There's very few papers that look specifically at saddle paresthesia, and on the face of it, this paper showed good outcomes for paresthesia. If you look at their data, and I've highlighted it there, About 41% of patients had saddle paresthesia before treatment and only 10% after. The problem is if you go along that line a bit and delve a bit further, only a third of patients with CESR were said to have had perineal numbness before surgery. Usually CSR is associated with perineal numbness. So I don't know how to interpret that. And even more unusually, if you look right over at the right-hand side, the so-called CESS, more than half of those patients had saddle paresthesia. Whereas I would say if someone had a massive disc and saddle paresthesia, I would call that CESI. If you look at the painless urinary retention data, of course, that was one of the definitions of CESR. So 99% of patients had that, but they showed significant improvement with treatment. So does that turn CESR treatment on its head, or does that suggest that perhaps categorizing patients into CESI or CSI is difficult, and perhaps some of these were incomplete? The Shrikandaraja paper was another local series, about 200 patients, again looking at bladder outcome at first outpatient visit. And the headline outcome here is that surgery within 24 hours, the CESI improves outcomes. This is their table, and on the left you've got time intervals. So the first two lines are within or after 24 hours, then the next section within or after 48, etc. And if you look at the within or after 24 hours, they showed definitely improved bladder function within 24 hours. If you do the maths on this table, you can actually work out that 24 to 48 hours is better than after 48 hours as well. So that was some important data. Reflecting back on the ARN data showing no difference less than 24 hours versus 24 to 48 hours, they showed in this paper that within 24 hours you had a 2 times increased likelihood of a good bladder outcome rather than 24 to 48. And if you operate within 24 hours versus after 48, 5 times increased likelihood of a good bladder outcome. In terms of thinking of a continuum of harm and a time-dependent effect, which is certainly the way I tend to interpret the literature, this graph is also important. If you look at all 3 time intervals, before or after 24 hours, 48 or 72, for each time interval, there's a better outcome with earlier surgery than surgery after the set time interval. There's then been some recent literature, and I have had some people contact me about this literature a little bit glum, thinking that this turns everything on its head because it shows that Cauda Equina patients do very badly. And just a word of caution, if an opinion is given that surgery within 24 hours is likely to be associated with a good outcome, of course, we're talking about 50% here. And I'm afraid the truth is not that every case of Cauda Equina syndrome can be completely rescued with early treatment. Unfortunately, there will be people even with early treatment that have a bad outcome. And so whilst it's not true to say that if everyone had very early surgery, they would all be cured, it's also not right to say that if everyone with CESR has a terrible prognosis. The Hazelwood review was a telephone questionnaire, really, with only a 60% uptake rate. And this is one of the reasons all of these retrospective analyses needed to be treated with caution. And they did demonstrate a high prevalence of long-term bladder, sexual and physical dysfunction, that's true, but it was absolutely not a study about timing of surgery and really doesn't give any useful data on that. If you look at these headlines, they're pretty grim. Planty bonjour, poor recovery prognosis despite early treatment. That sounds pretty awful. And the Norwich paper, Barker, showing a high rates of ongoing autonomic dysfunction at 5 years. But you really mustn't just read the headlines or the abstracts of papers. It's very important to delve into the detail. So Planty bonjour was another database study, potentially open to the same statistical criticisms as all the other case series. Half of the patients had CESR, so we would put them in a higher risk group potentially for not doing well. And what was their early treatment? Well, they state that the median time from CES onset to diagnosis was 4 days. Well, if you remember the graphs I showed you about UK real world data, that's quite late. The UK are doing better than that. The Shrikanda-Raja time groups, 24, 48, and 72 hours, are all well within what is the median time to diagnosis, not even treatment for this paper. It's not really a study of timing in surgery. They've given some data, here it is, about a multivariate analysis, but there's no data about how many patients were in each group, whether they were CESR or CESI. It's not really an attempt to solve the problem of timing. It's a database review. So even given all those caveats, if we look at genitourinary and bowel recovery, their headline outcomes, remember this is a series of half of the patients have CESR and the mean time to diagnosis is 4 days, quite late I believe. Less than 50% have ongoing urinary dysfunction, less than 50% have ongoing bowel dysfunction. There was a high rate of ongoing genital symptoms. So are their conclusions justified? Well, the key points aren't really conclusions at all. CES remains very disabling and mutilating. I can't disagree with that. There's a dark prognosis, yes, especially if you've got CESR and late surgery. I'm not sure that a comment on early versus later surgery is really justified to the data they presented. And illuminatingly, if you read their conclusion, they state decompression should be done as early forward as possible. Well, I agree with that statement, but I don't understand how they come to that conclusion the way they presented the data. And they also state the only way to prevent CES is to educate the patient. I would argue that that has to go along with early surgery as well. The Barker paper, another local review, a 75% response rate. So the usual caveats about what were the characteristics of the patients we didn't contact. This is a very representative UK study. The majority was CESI, about a quarter CESR, and they stratified less than 48 versus more than 48 hours. Only about a third were within 48 hours, 2/3 after 48 hours. And they made the point that CESR is more likely to present early. If you look at the CESI data, just a quarter within the less than 48 hours group. So there's only 12 patients in this study having CESI surgery within 24 hours. So it's not very many. Headline figures for all comers, including CESR and the late surgery group. I'm sure your lawyer's eyes will pick up that many of these numbers are below or only just over 50%. So in terms of an opinion on causation with early surgery, I don't really think this data blows the concept of early surgery being associated with a better outcome out of the water. If you look at specific data for the CESI patients, post-op symptoms such as incomplete bladder emptying, abnormal filling sensation, or urinary incontinence are only just over or much less than 50%, including the late surgery group. As for sexual dysfunction, similarly, significantly under or only just over 50%, including the late surgery group, with much worse outcomes for the CESR patients. So I'm running out of time. Perhaps I have run out of time. Apologies. Where does this leave us on causation? Sadly, I won't give you a blueprint that can be stamped on every report because there's a spectrum of clinical presentation in terms of speed of onset and severity of Cauda Equina symptoms, and individual patient characteristics do matter. The quality of clinical studies is necessarily limited. We're reliant on retrospective case series. These are difficult to compare, and experts will continue to argue the relevance of particular studies to the overall literature. In my view, the overall literature does suggest that an early presentation with complete loss of perineal sensation, urinary retention, and incontinence likely indicates a poor prognosis whenever you operate. But do remember, some CESR patients do recover. Surgery for CESI within 24 hours of symptom onset is likely associated with a better prognosis than delayed surgery, but that doesn't mean that everyone will be cured of symptoms. I sometimes get asked about a time-dependent effect in the absence of clinical progression. And in other medical pathologies, obviously, if there's evidence of a neurological deterioration in the period of breach, then that's very helpful for causation. But the Cauda Equina data really deals just with timing. and I don't think we're reliant on showing significant clinical progression as well. There remain significant clinical controversies. I'd love to have another session perhaps with a urologist talking about the bladder, because it can get complicated. Our main problem clinically is getting a Cauda Equina patient into a DGH MRI scanner as an emergency 24 hours a day. The national guideline may come out and say do the MR within 4 hours of request, which would be big progress. Post-void bladder scans, I've not touched on them, it's a big area. Some surgeons believe in them and will use a post-void bladder scan of less than 200 mils as a screening tool to delay imaging. Others, and I'm in the other camp, feel if you've got serious concern of Cauda Equina and you're not retaining volumes of urine, then that's the patient you want to get an emergency scan and treat them before they start having impaired bladder emptying. There's a problem, and this has been debated in court, about what is CESR, or loss of executive function. In the modern medical era, we don't let patients get huge bladders with overflow incontinence. And so deciding when CESR starts can be really quite difficult. Thank you very much all for listening. Please do ask questions, and there's some contact details for me there if you'd like to get in touch in another method. Thank you very much.
That's a wonderful talk, John. Thank you very much indeed. And we have got a couple of questions which have come in. The first question is, what is the defining factor when diagnosing radicular pain in comparison to other types of pain, such as facet joint pain or orthopedic pain?
Yeah, that's a very good question. And we find it surprisingly difficult to answer. And I guess one way to answer that is clinical judgment of 20 years of examining spinal patients. And it's difficult to put it down in a sentence, but a specific pain, an L4 nerve root pain, will be a particular pain down in the anterior thigh, through the knee, perhaps with some sensory disturbance in the shin. An L5 pain, typically buttock, and then down into the lateral calf. Nerve root pains have certain characteristics. Aching of claudication and referred facet joint pains tends to be more general, diffuse, less specific. So there's some of the clues that we have, but I think for a non-spinal specialist, it remains very difficult.
And the next question is a two-parter, in fact, John, relating to the overnight surgery point that you had. And the first question was, how do you reasonably balance those risks of complications against the risks of worsening outcome from delaying the compression when you're considering whether to go for surgery overnight?
Yeah, so there's a number of factors which you'd need to tease out in a case. One is, what's the time course of deterioration? So how long has the patient had symptoms for? Has there been progression over the last 6 hours, say? You know, do we look like we're definitely heading into a problem here where there's going to be progression to serious bladder problem if we leave the patient? What are the competing interests in theatre? Of course, we don't do spine in isolation. There may be currently, you know, life-threatening surgery going on, so you just can't get in for a few hours anyway. And the time matters. You know, it's 4:30. Really, by the time you get going, you're only going to make a couple of hours difference. You might be better off getting super organized and getting the team straight in there at 8:30 in a nice, fresh way. So there's a number of factors to consider. I think increasingly as spinal consultants on call, we wouldn't have any qualms about getting up in the night and going and doing the surgery at 4 in the morning if we felt that was really necessary. And you know, perhaps the world is changing in that respect. But when you're asking for a legal opinion, there's still a reasonable body that would make a very strong case that leaving it till the morning doesn't make a huge difference, and I need to be conscious of that.
And then the follow-up to that is sort of Montgomery point, which is that is any discussion about the increased risk to surgery overnight a Montgomery issue for the patient to consider and consent to?
Yeah, potentially. I mean, Cauda Equina itself is associated with a higher rate of complications, that's for sure. Severe back pain, dural tears, recurrent disc, they're more likely in a very large disc prolapse. there's always a chat when we do an overnight or an emergency consent. There is usually the timing of surgery forms one aspect of that, and so I think that's reasonable. Do we say specifically, oh, if we operate in the night, you're going to have a much bigger problem in the day? Probably not, in all honesty. We probably don't want to worry the patient in that regard, but it plays more into our judgment about whether we're going to really push for that operation to happen in the middle of the night. We could probably improve in terms of informing patients about all of those factors.
Absolutely. Well, thank you very much indeed, John. Hugely appreciate it. And that was a great talk.